Now, in liver, what is happening? Increased gluconeogenesis. What do we understand by the word gluconeogenesis? No. Genesis means formation. Lysis means breakdown. Genesis means formation. So, gluconeogenesis, what is happening? Non-carbohydrates, yes. Those food products which is non-carbohydrate, our liver tries to do what? Convert it into carbohydrate. That process is known as gluconeogenesis. So let's say you are not taking carbohydrate, but whatever food you are taking, liver is converting everything into glucose, into carbohydrate. So more amount of gluconeogenesis will lead to diabetes, can lead to diabetes. These are the precipitating factors. Okay. Now in intestine, what is happening? Whatever diet we are taking from the intestine, it is getting absorbed, right? Now let's say intestine should have absorbed 100 amount of glucose from the intestine. Just an example. Now the intestine is doing what? 150 amount of glucose it is absorbing from the intestine. Means more and more glucose is getting absorbed. There are certain porters, there are transporter like SGLT1, SGLT2, that is a sodium glucose link transporter that you will be taught in physiology. These are some transporters which is taking up the glucose inside the intestinal cells. Now what is happening in the intestine? These transporters are working more and more is glucose is absorbed. So that can also lead to diabetes mellitus. Now another one is the kidney. Now whenever this glucose are absorbed from your intestine, these are going into what? Blood. This is circulating in the blood and blood is getting purified in the kidney. During the purification, some of the blood glucose will get reabsorbed and little bit of it will come out. Okay, which is normal, the normal range. But what is happening? The kidney is over functioning. If the kidney is over functioning and trying to reabsorb everything from the blood, whatever glucose is there, 100% of it is reabsorbing. So anything is coming out in the urine? No, nothing is coming out. So gradually the concentration of the glucose will keep on increasing because something should have came out. The normal blood sugar should have little bit of sugar should have came out, but kidney is reabsorbing everything of it. Okay, so that can also lead to formation of diabetes. So these are the certain causes how diabetes can develop. So for you, what you have to know, which are the organs which is responsible. First and most important organ is the pancreas, because of the hormonal dysfunction. One is the decreased activity of insulin and increased activity of glucagon. This is the first important point that you have to remember. Okay. Other than that, there are certain factors. That is, one is the intestine, which is absorbing more, kidney, which is reabsorbing more, and then another one is the liver, where the non-carbohydrate particles are getting converted into carbohydrate particles. So obviously the glucose concentration or the sugar concentration increases in our circulation. Done? Okay. Now what are the criteria to diagnose DM? Now these criteria you have to remember certain things. Now whenever a patient comes to us with a certain symptoms, like the common symptoms that has already been taught to you is polyphagia, polyuria and polydipsia. Anybody tell me what is polyphagia?
Increase amount of appetite.
Increase hunger or increase appetite. Okay. And polydipsia?
Increase water thirst.
Increase thirst. And polyuria? Increased urination. Everybody knows the reason behind it. Why polyphagia is happening, why polyuria is happening and polydipsia is happening.
Diabetes mellitus.
Yeah, why? Why this is happening?
To provide more glucose level. To decrease the glucose level and extract out the glucose level.
पहला वाला जो बोला था वो सही था. To increase. Why polyphagia is happening? You are taking food. Your insulin should have broken down the carbohydrates and should have given you energy. Okay. Now insulin is unable to break down for whatever the reason is. Either the insulin is less or it is ineffective. That we will learn later on what is happening with the insulin. So insulin is unable to break down the glucose. Now your body needs energy to function. What body does? Your body produces hunger. You have to eat more so that food you are taking that gets broken down and you can meet the energy requirement. Okay, that is why you are having polyphagia. Whenever the circulating blood sugar is more in your blood, which is getting out through the kidney in the urine, what is happening? Whenever the sugar is coming out, it is taking out water along with it as well. So that is why polyuria is also happening. Frequently you are feeling like passing urine, and if you pass more and more urine, obviously you will get dehydrated and you will feel thirsty. That is why polydipsia is. These are triad of diabetes. Okay, so these can be asked to you: why polyphagia is happening, why polyuria is happening, why polydipsia is happening. These are more important for you to know because these are the physiological basis. Okay. Now, criteria for diagnosis, what should be the lab findings? If a person comes to you, you have to check certain investigation that you have to do. One is the early morning empty stomach blood sugar level. That we are telling as the fasting blood sugar level. Okay, which have to be more than 126 to call it a diabetes. 2 hour postprandial means the patient comes to you, gives the blood at the early morning in an empty stomach. After that, you tell the patient now you have food. and after having food, after 2 hours of the meal you have taken, you will again give the blood sample. That is known as the postprandial, 2-hour postprandial blood sugar. Okay, that should be more than 200 to call it a diabetes. HbA1c is a glycosylated hemoglobin. What does is, whenever your body has more amount of glucose, okay, now glucose has a tendency to bind with the hemoglobin. Let's give you an example. Let's say there is an RBC cell, okay, in the RBC there is hemoglobin which is there, which is bound to the RBC. Now this glucose which is circulating in your blood, this will come and bind with the hemoglobin. That is known as the glycosylated hemoglobin. Okay, now whenever this circulating glucose is more, obviously more amount of glucose will bind with the hemoglobin, right? So this glycosylated hemoglobin level will also increase. That is known as the HbA1c. So whenever we are measuring the HbA1c, we are seeing how much amount of hemoglobin is bound with glucose. Okay, so if the range is more than 6.5%, it is diabetes. If it is between 6 to 6.5%, then it is a pre-diabetic stage. Okay, the patient did not develop diabetes yet, but soon the patient will develop, unless if the patient do not maintain his diet, lifestyle, habits. If he doesn't maintain that, then the patient will develop diabetes. And if it is less than 6, or to some book it is given as 5.8, okay, if it is less than that much, then it is normal, fine. Okay, so this much amount of hemoglobin will bind with the glucose, but if it is more than that, more than 6.5%, then it is diabetes mellitus. Okay, you got it. Now we say that the HbA1c gives us, now let's say somebody is having blood sugar of 130, fasting blood sugar of 130. Now there could be two conditions. Probably the patient who gave this blood sample early in the morning, yesterday he had 10 or 20 sweets. So obviously next day his blood sugar will be little bit raised. So 130 we will be thinking that probably the patient is having diabetes, but it could be because of his diet as well. So that's why we have to cross check with the HbA1c as well. Why? The HbA1c will give you a, not just a value of yesterday's, it will give you a value of around 3 to 4 months average. How come? This question can also be asked, how come HbA1c gives you a value of 4 months average? Like, I am taking food every day. Yesterday I took more food, today I am getting more blood sugar through the fasting blood sugar or the PPBS. Okay, but HbA1c makes it average over the 3 to 4 months. How come?
RBC lifespan.
Exactly, good catch. RBC lifespan is 90 to 120 days. Okay, 120 days we say, 90 to 120 days. So whatever glucose is binding with the hemoglobin, that is going to stay over there for 90 to 120 days. That is why with 1 day's diet, this will not change. Okay, so that's why when you are averaging over 3 to 4 months, that's why you get a better result. That's why if somebody is asking which report you have to be more dependable report is HbA1c. But yeah, you have to see everything. Okay, you have to see everything, but more dependable is HbA1c, because that gives you, relieves you from the bias that you can have because of the diet. Yesterday the patient has more amount of glucose intake and the patient is having more amount of report. It cannot be, it can be false as well because of the dietary changes it changed. Fine, understood? Now there comes random blood sugar, like any random moment. Like let's say right now I want to check my blood sugar. That is random, anytime. These two were fasting, early in the morning, then after 2 hours. Okay, this is random, anytime you can check the blood sugar level. And if it is coming more than 200 milligram, as well as the symptoms are there, symptoms can be polyphagia, polydipsia, polyuria. If these kind of symptoms are there along with random blood sugar is more than 200, that means it is diabetes. Okay, now another comes the C-peptide level measure. C-peptide level is a measure of the endogenous insulin level. What is happening? I told you that the insulin is getting secreted from the beta cell of the pancreas, right? Now can you measure insulin level in our body? Can you measure the insulin level in our body? We cannot measure actually the insulin level. Okay, so what we see, what is there? Let's say this is a beta cell. Okay, let's say this is a beta cell. Beta cell is releasing what? Insulin. Okay, and beta cell is also releasing C-peptide. Okay, now let's say something destroys this beta cell. Okay, if the beta cell is functioning properly, the insulin secretion should be normal. Fine. Now something destroys this beta cell. Obviously insulin will not come. into the circulation, neither C peptide will be coming. So we can measure the C peptide from the blood. Now if we measure the C peptide, that means if the C peptide is normal, means beta cell is functioning normally, and if the C peptide is low, means beta cells are getting destroyed, and the insulin that is secreted in our body, that is also less. Got it? So by measuring C peptide level, we can measure the amount of insulin which is there in our body. C peptide low means insulin is also low, that is secreted from the body, and it is secreted inside our body. There can be two types of insulin. One that the pancreas is secreting, another that we are taking through the injection. If we are taking through the injection, that is known as the exogenous source of insulin, which is coming from the pancreas, that is known as the endogenous insulin. Okay, endo means inside, from inside. That is why C peptide level is a measure of the endogenous insulin level. If somebody is a diabetic patient and taking insulin, we cannot measure that properly. Why? Because C peptide will measure only the endogenous. But from the outside, whatever you are taking, you cannot measure that. Fine? Okay. Anybody has any doubt in this one? Okay. Now there are types of diabetes mellitus. How many types can be there? First of all, we know already that there are type 1 and type 2. Since last decades, we have been knowing that there is something more things, not just 1 and 2. There can be 1.5. In 1.5, there are subtypes like KPD, LADA. KPD means ketosis-prone diabetes. LADA means latent autoimmune diabetes in adults. Type 3 diabetes is also known as the hybrid diabetes. Let's go to type 3 later on. First, clear the confusion between the type 1, type 2, KPD and LADA. What is happening in there? Okay. There are multiple slides I'll show you. No need to remember all of it. Okay. First of all, see the age groups when it is happening. The type 1 is happening in very early age, that is 15 to 20 years of age. Type 2 is happening in a late stage, that is 30 to 35 years of age. What is happening in case of type 1? There are certain antibodies. This is an autoimmune disorder. Autoimmune disorder, how I have to make you understand. We know that our body has immunoglobulins, which is our immune system, right? Our immune system's work is what? Immune system goes and kills the foreign objects, right? Now, let's say there is a haywire in the connection, and what is happening? Our immune system is killing our own cells, right? If our immunity system is killing our own cells that is present in our body, that is known as the autoimmunity. Means self-immunity is killing our cells which is necessary for our body, right? So, type 1 is an autoimmune disorder. Okay. What is happening? There are certain antibodies. Okay. Antibodies function is to kill the antigen, right? So certain antibodies are there which is killing the beta cells, right? If they are killing the beta cells, the C peptide level will be low. So C peptide is low. Okay, up to this much is fine. This is how type 1 happens. Understand this much. Type 2, what is happening? It is not an autoimmune disorder. Over here, what is happening? There is insulin resistance. Resistance means what? The body is releasing insulin, but this is not working in your body. Okay, that is how the body is getting resistant, and it's a slow process. This is an acute process. Acute process means this can develop within days to weeks. Within days to weeks, this can develop. Okay, if it is developing between days to weeks, then all of a sudden body is having crisis of insulin. Okay, because the beta cells are getting destroyed, insulin is not coming only, so body needs energy. Your body have to function. So body does what? For energy, body breaks down the fat. You already know during Rothera's test, ma'am has told you people, right? So body tries to break down the fat because it's a very severe condition. Within a short span of time, it is happening, and body needs time to cope up. If your insulin is decreasing gradually, body will try to cope up with it. Like let's say right now you are having 100 amount of insulin, and in next 5 years this 100 amount of insulin is not working. Only 80% of it is working, and rest of the 20% become resistant, which is happening in this case. So body is coping up. Gradually the body is trying to cope up with it. When the body will not be able to cope up, they will present more and more symptoms. Right? So that is why this is a slow process. Okay? And this is a very acute, or you can say fast process. Okay, so if it is a slow process, and over here there is the insulin resistance which is going on. Okay, so over here there will be ketosis which is present. Ketosis present means diabetic ketoacidosis. Why it is happening? Because of the metabolism of the fatty acids. Because you need energy. Your body is trying to break down the fat, and that's why ketosis is happening. And the ketosis present means DKA, diabetic ketoacidosis is present. And that is why this is a very severe form of disease. Understood the keywords? The sequence? Over here it's a slow process, insulin resistance is there, there is no autoimmunity. No autoimmunity. No antibody also. Understood, right? And the C peptide will be normal. Yeah, C peptide is normal. Right? Any difficulty in understanding this much? So this is your first difference between, over here, because this is a slow process, there will be no ketosis as well. So ketosis is also absent, and that's why it's a mild form of disease. So you have understood between type 1 and type 2. Fine. This is the major part that you have to understand first. Understood? Now KPD and LADA is little confusing but very easy to understand. Okay. See, type 1 there is ketosis happening, and over here the name is what? Ketosis prone diabetes. So that gives you an idea that over here ketosis will be happening definitely. So we write that ketosis is present. Okay, but in case of LADA, the name is what? Latent. Like latent autoimmune diabetes in adults. Why adults? Age group is adult age group. Fine. Autoimmunity means over here autoimmune disorder. Autoimmune disorder. Okay. So these and these, some similarities, autoimmune disorder. And these and these, the similarities, this is also because of insulin resistance. Okay. Got it? Now this resistance was slow. This resistance is fast, very rapid. And because of that, the ketosis is happening. Whichever is fast, ketosis will happen because body needs energy to cover that up. And whenever the ketosis is happening, that means decay is present over here. Decay will be there, and it's a severe form of disease. Done? If it is because of insulin resistance, C peptide normal will be? Normal. So C peptide is normal. Right? And antibody will be absent. Right? Antibody absent. Done? In case of LADA, what is means? Latent. Latent means sleeping. It is hidden. It's a slow growing process. So it's a slow process. Even though it's an autoimmune disorder, over here the autoimmune disorder was fast. Over here the autoimmune disorder is slow. Basically these two are the opposite, exact opposite things. Understood? These and these are autoimmune disorder, but this is slow, this is fast. These and these are insulin resistant disorder, but this is fast, this is slow. एक चीज याद रखना, जितना यंग एज होगा उतना रैपिड ऑनसेट होता है, जितना ओल्ड एज होगा उतना स्लो ऑनसेट होता है. ओके, दिस इज द इजी वे टू रिमेंबर. कम एज आ रहा है मतलब फास्ट ऑनसेट होगा, कीटोसिस होने का चांसेस ज्यादा होगा, सीवियर फॉर्म ज्यादा होगा. लेकिन डिफरेंस कैसे समझोगे? लेट्स से वन बॉय कम्स विद 20 years old and presentation is with DK, diabetic ketoacidosis. That means in the urine you are getting sugar, ketone body, as well as acidosis is also happening, right? So how to understand whether it is a KPD or a type 1? You have to see the antibody or the C peptide level. If the C peptide level is normal, KPD. C peptide level is low, type 1. Done? Older patient is coming, there is no presentation of ketosis. The patient will come like polyphagia, polyuria, polydipsia, blood sugar is raised, or some organ disorder can be there, kidney or some eye problems are there, and you have to confirm whether it is a type 2 or LADA. How will you check? Again you check the antibody C peptide level. If it is low, LADA. If it is more, Normal or no, that is type 2. Fine, understandable? Okay, so this is what is the types of diabetes. Okay, and this much you have to remember. Over here there is many things. I will let you write all of these things, but if you understand this thing, it's done. Nothing more you have to do.
These two are like hybrid of.
Yeah, these two are the hybrid forms of 1 and 2. That is why these are the newer concepts. Okay, these two are newer concepts. Whenever you are reading, first read the type 1 and type 2. Once you write down this 1 and 2, then after that you have to compare 2 with KPD and 1 with LADA. If you compare like this, you will get it. That's all. Okay, I'll try to highlight in this part so that you can understand more better. This is autoimmune disorder. This is autoimmune disorder. Okay, this is insulin resistance. This is insulin resistance. See the colors. Okay, over here the C peptide is normal. Over here the C peptide is normal. Here ketosis is absent. Here also ketosis will be absent only.
Ketosis severe or mild?
Mild. Why?
Slow process.
It's a slow process. The body is getting the time to cope it up. Okay. This is also a mild disease. Remember one thing, whenever there is ketosis, it's a severe form of disease. Patient, if you don't treat the patient within few hours, the patient will die. You can't treat this patient. In a
Ketosis is high, we can say his metabolism is also high.
Yeah, fat metabolism is happening more and more. That is why the ketosis is happening.
So the person will be kind of malnutrition.
Not malnutrition. What is happening? The ketosis presents within 2-3 days. The ketosis will happen. What is the formation of ketone bodies? When you will get more ketone bodies? Prolonged starvation. Prolonged starvation can occur after 48 hours. Okay, I'm not going into that. Okay, these are multiple causes. For now, we have to understand prolonged starvation. Let's say in this case, the patient is having less amount of glucose in his body, or the glucose which is more but cannot metabolize it. Okay, if the patient cannot metabolize the glucose, obviously he needs more energy, so he goes for the breakdown of the fatty acids, and in the beta oxidation of the fatty acid produces the ketone bodies, and that is why the ketone bodies are getting more and more, and which is not getting any idea to come out, and they are causing that acidosis.
Ketosis will be there only if it is sudden, or it will be
Sudden, if it is sudden. If it is gradual,
the body takes time to cope up.
yeah, body needs more time to cope up in these two cases, but body is not getting the time only.
Ketosis will slowly go down, right?
It will not go down.
Age, like body gets time to cope up.
If the development of the disease is taking more time, then the ketosis will not happen.
No, I am asking if a person has type 1 and KPD, so it will be fast. But later in age, later stage.
If the patient is maintaining with proper medication, then the ketosis will not develop. If let's say somebody developed ketosis, okay, somebody is presenting to you with decay only. Now you have given the treatment to the patient. He is out of danger now. Now you have fixed some insulin dose or oral hypoglycemic agent, oral medication to the patient. Now the patient is maintaining everything properly. Then the patient will not develop with ketosis. The patient might have hyperglycemia, might have hypoglycemia, but will not present with ketosis if the patient is taking dosing properly. Now let's say you have given the patient medicine, but the patient is not taking it properly. Then again he can land up with ketosis. Okay.
It does not have to cope up with these.
No.
It will never cope up.
It will never cope up. Because it is happening within days to weeks. Your body, either it is not having the insulin only, or else the insulin is there but not working only. In both the cases, what is happening? Your body needs insulin to break down of the glucose. Your body is ample amount of glucose, but it cannot break down. If it cannot break down, your body needs energy. Somewhere or other, your body have to get the energy. That is why the ketosis is happening. These are the alternate processes of getting energy. And in that alternate process, when you are metabolizing the fatty acid, the ketone bodies are produced. That is what is known as ketosis, right? So all of a sudden, when the body is having changes, ketosis is happening. And if it is happening over a period of time, slow progression, very slow progression, then that time ketosis will not take place. The body is coping up with it. Let's say your insulin at age of 30 years. This is the mean age, like 30 to 35 years, that is the average age. Let's say at 35 years, your insulin efficacy is 80%. By 35 years it is 60%, by 40 years it is 40%, by 45 years it is 20%. So gradually it is decreasing. So this decrease, body is trying to cope up. Over the year it is decreasing, not within few days or weeks. Okay, when it is happening within few days to weeks, that time body is not getting the chance to cope up. Like मेरे पास तो इतना ही इंसुलिन है, मुझे इतने से ही मैनेज करना पड़ेगा. नहीं, उसके पास इंसुलिन 100 था, अचानक से 20 हो गया. Body will not be able to make it up, and body needs energy to work on. Got it? Okay. This much only in general you have to remember. Remember this chart. Over here I will be discussing rest of the portion. Okay. Now type 1, what is happening? Commonly seen in younger patients. We have seen commonly seen in younger patients. Autoantibodies are present. Therefore, the C-peptide level is also low. Autoantibodies are present, which is killing the beta cells. That is why C-peptide level is low. Family history is rare. Over here, you don't get family history. Okay, means the parents are not having diabetes. All of a sudden, your body is getting autoimmunity. Your immune system is acting against yourself. There are certain plus minus. I will whenever I will be showing the case, that time I will tell why autoimmunity is more important. Okay, patient build is thin. Patient is not obese, but in case of type 2, it's a slow process. The patient becomes more obese. Dyslipidemia is there. That is, lipid profiles are dearranged. Patient can have metabolic syndrome. Metabolic syndrome is if somebody is too fat, too obese, that time you can see some black marks in the neck region. Okay, that is known as acanthosis nigricans. Okay, that thing is a suggestive of metabolic syndrome is happening, that your lipid profiles are deranged. No need to see his one. Okay, so your lipid profile, if the lipid profile is deranged, if somebody is having dyslipidemia, they can have this. These are the early symptoms of acanthosis nigricans. So many often patients who is very obese and they don't understand whether they are having diabetes or not, and they present to the doctor like, sir, I am having this black color mark in my neck, it was not there before, all of a sudden it is developing. These are the early symptoms. These are the early signs that you can get. Okay, that can be seen in case of type 2, which is a slow growing process. But in case of type 1, it is already developing within weeks. There is no chance of getting this acanthosis nigricans. No time to develop all these things. Okay. Now decay is more common. Why? Sudden onset. जल्दी precipitate कर रहा है, so decay, diabetic ketoacidosis can happen. No acanthosis nigricans. Okay, and dyslipidemia is also absent. There is no concept of all these things. But in case of type 2, what is happening? Commonly seen in older patients. Fine. Its autoantibodies are absent. Why? It is happening because of the insulin resistance. That's why the C-peptide level is also normal or high. Family history are more common. This is more of genetical kind of thing. If the father and mothers are having type 2 diabetes mellitus, more chances that the offspring can get the diabetes mellitus, and that would be more likely type 2 diabetes mellitus. Type 1 mellitus is not familial. Okay, patient's build is obese. Over the period, the patient becomes more obese. There is more amount of dyslipidemia is present. Acanthosis nigricans is present, which is suggestive of the metabolic syndrome. And decay is very rare because it is a slow growing disease.
Yeah, but decay can be possible.
Possible if the patient is not maintaining the blood sugar level only. If the patient is let's say like the patient is on insulin, and the patient is not taking insulin only and taking more and more amount of glucose, obviously they can present. That is why it is rare. It is not that it is not possible. It is possible, but it is rare. Rarely it presents like that because it takes more amount of time.
Then if decay is present, then person will not be obese.
No, it can. Patient will be obese.
Fat will be more metabolized.
If the fat is getting metabolized, it is all of a sudden the fat is getting metabolized. Not over the period of time, fat is not getting metabolized. Patient is all over the time, patient is obese, having more amount of food, not getting metabolized properly, and patient is getting obese. All of a sudden, when the sugar is getting too much and insulin is not being able to work, what is happening? The body tries to go and metabolize the fat. And that is instantaneous, probably within 1 or 2 days. That is how the decay presents. Okay, in the last slide, why this build is thin? Because it's an acute onset. Over the year it is not happening. That is why the patient is maintaining lean and thin. Whatever the patient is eating, it is not getting metabolized. Okay, in case of this, thin things are not getting metabolized, but these are getting stored up. Okay, that is why they are getting obese. Over a period of time, like over years, I am talking about over years. And that is only mere over weeks to months at max. You are getting the difference. The more time you are getting, the more unwanted things are getting deposited in your body, and then you are getting obese. You are getting the metabolic syndromes. Right? Now, there is a case presentation. In case of A 16-year-old boy. So as soon as you are seeing the age group, you are suspecting what? It could be KPD, it could be type 1. Okay, right? Two things are coming in your mind. Now let's see. The patient presented to the clinic with complaints of polyuria, polydipsia and 5 kg weight loss in last 3 weeks. So some symptoms are there. Now he also reports of fatigue and difficulty in concentrating. Why fatigue and difficulty in concentrating? One thing you always remember, glucose is necessary for our body. For our brain function also glucose is necessary. If you are having low glucose or the glucose is not functioning, you will have fatigue. Means dizziness. Whenever you are having this less glucose in your body, you feel dizzy. Okay, sleepy, this weakness that can be there, and difficulty in concentrating, that is there in school. His mother notes that he has been eating more than usual. He is eating more and more. Like before he was eating less, right now he is eating more and more, but still appears thinner because whatever he is eating, this is not getting metabolized. Okay, and weaker. There is no family history of diabetes mellitus. There is no history. Mother and father is completely fine, no history of diabetes, but the mother is having hypothyroidism. Now hypothyroidism, one of the most common cause of hypothyroidism is autoimmune. Over there what is happening? The antibodies are killing the thyroid cells, thyroid producing cells. Those cells which is producing the thyroid hormones, that is going and killing the thyroid cells. So if the mother is having autoimmune disorder, the child can have autoimmune disorder. It is not likely that the child will have hypothyroidism only. Child can get type 1 diabetes mellitus also. That is what is the importance. That I was telling you that autoimmunity history is important. Family history is important. Over here you are not getting the history of diabetes mellitus. You are getting a history of hypothyroidism, which is more likely the patient who is getting that autoimmunity trait from the mother as well. It can develop without any history of hypothyroidism as well. It is not necessary that मम्मी का hypothyroidism या फिर पापा का hypothyroidism का history होना ही पड़ेगा. इसके अलावा भी हो सकता है. But over here you are getting a key point. Okay. Now finding what you are getting, the random blood sugar is more than 200. HbA1c is more than 6.5%. Serum ketones are elevated. Okay. If ketones are elevated means decay. So now you have ruled out these two. These two are ruled out. These two are not presenting with decay. These two can be the possibility. Okay. So your ketones are elevated. Now in enzymology you saw the C-peptide level is low. So if the C-peptide is low means type 1. It cannot be KPD anymore. Okay. And what are the antibodies which is destroying these beta cells? These are the two antibodies. Okay. One is the glutamic acid decarboxylase antibody. Another one is the islet cell antibodies. Okay. Glutamic acid works in the glycogen metabolism pathway and islet cell acts on the beta cells of the Langerhans. Right? Okay. So these two are the antibodies which is killing the beta cells. And as soon as you see the C-peptide level is low, you are coming to the conclusion of type 1. So this is how you have to rule out. Once you see the blood sugar is raised, means it is diabetes confirmed. Now you have to identify ketosis is happening or not. Ketosis is happening, it could be only these two. Not happening, these two. Okay. Once you got that ketosis is happening, then you have to see the C-peptide level. Low means type 1. If the C-peptide would have been normal in this case, it could be KPD. Got? Okay. Next, type 2. Another case. A 52-year-old, see the age group. More age group comes out towards this much. More towards type 2. But can be LADA as well. No, we don't have any idea. Now, obese patient, obesity. Here, both the places you will get obesity. Okay, because it's a slow process. BMI is 32 kg per meter square. Everybody knows how to measure BMI? Weight in kilogram, height in meter. Meter square. Divide the kilogram divided by meter square. Khatam, ho gaya. Normal BMI 18 to 24. Okay, if it is more than that, then it is obesity. Okay. Now presented in the OPD with complaints of fatigue, increased thirst, frequent urination over the past 3 months. Since 3 months he is having the symptoms, but these things has been going on inside his body since last 10-20 years probably. Got it? He is a known case of hypertension and dyslipidemia. So he is a history of dyslipidemia, which is significant for this case. And the father is also having type 2 diabetes mellitus history. So family history is also present in case of type 2. The patient is having a sedentary lifestyle, that is less exercise, more of junk foods, fatty foods, irregular habits, that is sedentary lifestyle. Now, physical examination of the patient is having dark patches on the neck and the axilla, that is acanthosis nigricans, symptoms of metabolic syndrome. So all the things are given to you one after another, which is coming to you, telling you that it is more likely type 2, more likely type 2. But still we are having a doubt whether it is autoimmune or this. Now you are seeing over here RBS is 280, fasting blood sugar 160, everything is high. If you see HbA1c is 8.5%. In case of type 1, how much was it?
16.
See how severe is it? Okay, and see how severe is it. And this is a showing average of last 4 months. Okay, but the symptom precipitated within last few weeks. Okay, since last 4 months the patient is having these symptoms, but symptom is developing within 3 weeks. So that is why this is a acute onset. Symptoms are going on inside your body, but the body is not showing you symptoms. Got it? Body is showing symptoms since last 3 weeks. Over here, this is 8.5%, means even less than that. But the patient is having symptoms for last 10-15 years. Got it? What the difference? Now, urine analysis you did, you see the glucose is present and ketone bodies are absent. As soon as you see the ketones are absent, means these two are ruled out. It can be only this or this. Now, among all the symptoms, whatever is written over there, family history is present, dyslipidemia is present, this what is there? Acanthosis nigricans is present, which is going towards the diagnosis of type 2. Okay, if they would have mentioned this autoantibody is less, if they would have mentioned over here C peptide is low, C peptide is decreased, then it could have been LADA. Okay, C peptide is normal in case of type 2. Got it? Any doubts? Everybody fine with it, right? Okay. What are the enzymatic changes that we can see in case of type 2? First of all, insulin resistance due to impaired function of the insulin receptor substrate. What do we mean by that? Let's say there is a glucose particle, okay, and there is an insulin particle. Now, insulin has some receptor which is binding with this receptor, okay, then it is acting, okay. GLUT4 is a transporter, okay. So, insulin has some receptor. This receptor is known as the insulin receptor substrate. This is the IRS, okay. Now, this is not functioning. If this is not functioning, this will not bind with this. Okay, and the work of the insulin to metabolize the glucose is not happening. Okay, but if you're giving insulin from outside, do you think that this will also have the problem with IRS? No, that is a normal insulin. The body which is producing, that is having the defect with the insulin receptors.
This is for which case?
Type 2. Okay, where the resistance is developing. Why the resistance is developing? Because this is not functioning. Some are functioning, some are not functioning. The more this becomes deactivated, this receptor gets deactivated, the more resistance it will develop over the period of time. Got it? Now, increased hepatic gluconeogenesis. What is happening in increased hepatic gluconeogenesis? More amount of non-carbohydrates are getting converted into carbohydrates, right? How come increased hepatic gluconeogenesis can happen? Because of the two enzymes. One is PepsiK, another one is the glucose 6 phosphatase enzyme. Can anybody tell me where you have heard this enzyme before? Glucose 6 phosphatase enzyme. Which disease?
This type 1.
Yeah, type 1.
Carbohydrate.
Glycogen storage disorder, von Gierke's. If the glucose 6 phosphatase is not working only, where the glucose 6 phosphatase is defective, because of that von Gierke can happen. Okay, over here what is happening, this PepsiK, that is the phosphoenol pyruvate carboxykinase, and glucose 6 phosphatase, both are overly functioning. Excess functioning of these two can cause increased amount of hepatic gluconeogenesis. And if it is doing more and more, obviously more and more glucose will be there in your body. Even though you are taking less carbohydrate, more and more glucose are there because of this mechanism. Okay, so from here question can be asked like which enzyme is helping in increased hepatic gluconeogenesis. This is the question that can be asked. Nobody will ask you tell the enzymatic changes what is happening. This can be asked which receptor is responsible for the insulin resistance. Like this the question will be asked. So everything you don't have to write down. Certain things whichever can be asked. One is the identification of the cases. Second is this kind of multiple choice questions can be asked. Adipose tissue dysfunction. When the adipose tissue or the fat tissue that we say, adipose tissue is dysfunctioning and causing more and more amount of lipolysis. If lipolysis is happening means fat tissues are getting broken down. Once the fat tissues are getting broken down, increased amount of fatty acids is coming into our circulation. That can also lead to insulin resistance. Why? If the more amount of fatty acids are circulating, body tries to metabolize them first. Because the fatty acids are getting more, body tries to metabolize that first, and glucose keeps on circulating. So that can lead to hyperglycemia. Okay. Now decreased activity of the glycogen synthase. Glycogen synthase, what is happening? Let's say there is a glucose in our body. Okay, and the circulating glucose is, let's say, 200. Okay, now our body do not need that much amount of circulating glucose. So body does what? Keeps 80 to 100 in circulating form, and rest of the 100 it will convert into glycogen and store it in the liver. Whenever body requires, that time it will come out. Right? That is what is happening in normally. And glycogen synthesis, this glycogen conversion is happening with the enzyme glycogen synthase. Now, if there is decreased activity of glycogen synthase, obviously the excess glucose is not getting converted into glycogen. And if the excess glucose is not getting converted into glycogen, then the glucose concentration will keep on rising in your body. The circulating glucose will be more. Understood? Yes. Any difficulties? Anybody?
Number 4 point. Number 4 point.
Yeah, number 4 only I am saying. Let's say in our body there are, what is the normal glucose level? 80 to 110, right? Our body requires, let's say, just giving you an example, our body requires 80 to 110 amount of glucose which is circulating in our body. Right now, after you had your food, your body has 300 amount of glucose. Your body doesn't need that much. Your body will keep 100 to 80 to 110. Rest of it will get converted into glycogen and it will keep it stored in the liver. Okay? जब body में glucose कम होगा, that glycogen will come, it will have glycogenolysis and give you the source of energy. Got it? Now your body, because of this deficiency of this enzyme, the excess glucose which should have been converted into glycogen and stored in the liver, that is not happening. It stays in blood only as a circulating glucose. So the glucose concentration in your blood is more.
There only GLUT4 is involved.
In case of?
Means if it is normal, activity is normal, then GLUT4 will transport in liver and skeletal muscle.
Yes, GLUT4. GLUT4 is responsible. That is a transporter. Here it is important that GLUT4 is important. There are multiple GLUTs. GLUT1 is there, GLUT2, GLUT3, GLUT4, GLUT5. Multiple GLUTs are there. In this case, in case of liver and skeletal muscle, GLUT4 is important. Good catch. Okay. So because of glycogen synthase deficiency, the conversion of glucose to glycogen is not happening. And because of that, circulating glucose is more and hyperglycemia is happening. Okay. Another point is reduced glycolysis due to impaired activity of hexokinase 2. When you have read about the glucose metabolism or carbohydrate metabolism, there was glucokinase, hexokinase, these kind of enzymes were there, right? So because of deficiency of the hexokinase, the glucose metabolism is not happening. Okay, if the enzyme is not there, who will break down? Who will continue the steps? Okay, somewhere or other, glycolysis is happening but partial. Rest of the glucose is circulating as it is. So 4 number point में क्या है कि ग्लूकोज से ग्लाइकोजन स्टोर नहीं हो रहा है. 5 नंबर पॉइंट पे क्या है कि ग्लूकोज का मेटाबॉलिज्म नहीं हो रहा है. अल्टीमेटली दोनों में ही ग्लूकोज का कंसेंट्रेशन बढ़ रहा है. दैट्स ऑल इन सिंपल वर्ड्स. गॉट इट? ओके. आई डोंट नो इफ पीपल आर हैविंग एनी डिफिकल्टीज, प्लीज काइंडली आस्क मी. ओके. Now comes the type 1.5 KPD and LADA. Same thing that I have already explained over here, that is written as a chart. Like in case of LADA, these are young adults. Okay. In case of KPD, young adults but much lesser age. The age group is less in case of KPD. The younger age group, the severe the presentation. Okay. You don't have to remember the gender presentation. One is insidious, another one is explosive. What is explosive means all of a sudden outcome is happening, and insidious means gradually, slowly progressing. Right? So LADA is insidious and KPD is explosive presentation. In case of KPD, there can be obesity as well. This is one difference that can be there. Over here, this should be more lean patient, but some in books that is written that it can be obese as well. It can be obese, it can be lean, but we are not diagnosing with this thing. Okay, our diagnosis point of view is the C-peptide levels. Now ketosis, in case of LADA, ketosis is uncommon, and KPD नाम में ही है ketosis prone diabetes, so obviously ketosis will be there at presentation. Whenever the patient is developing symptoms, ketosis will definitely be there. What about the autoantibodies? The autoantibodies is less in case of KPD. That is what is helping in diagnosis between type 1 and KPD, depending upon the autoantibodies, because because of insulin resistance which is developing all of a sudden. In case of LADA, it is नाम में ही है, latent autoimmune diabetes in adults. So autoimmunity is there, antibodies are present. Got it? And if a patient comes with that severe stage, whose blood sugar is very high, patient is coming with acidosis, we cannot treat them with oral tablets. We have to give them insulin first. So first treatment is insulin. Once the patient is better, then we can give tablets. That they have to continue. If they fail to maintain it, then again they will present with ketosis. That you were asking. Okay, if they fail to maintain it, then again they will present with ketosis. Otherwise, they will be normal only if they maintain the medicine. In case of LADA, this is already a long-standing case. Okay, so initially we will try to give them oral tablets. If they are maintaining good with oral tablets, continue it till the time it is maintaining. Once the oral tablets are not maintaining, then you have to shift to insulin. That is why initially oral hypoglycemic agent, later on we go to insulin. But in case this is opposite. Right? Treatment you don't have to remember, just for your understanding purpose. Thing that you have to remember from this whole point of view till now is this chart. This chart you have to remember. That's all. You don't have to remember anything from the slides. The slides are just to make you understand. This is just to make you understand, but this part you have to remember. Got it? How to identify a case, which things you have to look into. Done? Then comes your this enzyme. These are the short questions, one short line questions, MCQ questions that you have to remember. So at the end of the class, you have to write down this and this enzymatic defects. Okay. Now type 3 and type 4. Type 3 and type 4 is more or less easy things. Easy things. I have told you that in the first slide, pancreas is responsible for releasing two hormones. One is glucagon, another one is insulin. Both of them can cause diabetes. If the glucagon is more, diabetes. If the insulin is less, diabetes. Let's say you have been told already in your clinical classes about acute pancreatitis, right? There was a class discussion because of some patient who is taking more amount of alcohol, amylase lipase is increasing. Let's say somebody had this pancreatitis. Over the period of time, the patient had pancreatitis. That became chronic pancreatitis. When the patient is having long-standing pancreatitis, what happens? The pancreas, once it gets inflamed, means it gets dilated, bigger. Then, when it heals, it shrinks and becomes fibrosed. Means very small size pancreas will be there. Okay, because the tissues are getting first inflamed, then destroyed. Once they get destroyed, there will be fibrosis and they will shrink. And there will be small amount of calcification. Calcification means stone formation. Small stones can be there. Okay, and those stones because of calcium deposition inside the pancreas. What is happening if the stones are there? The ducts which is releasing the hormone, they can get blocked, and these tissues which is having first pancreatitis, those are also getting dead. Once the cells are getting dead, endocrine glands are only getting dead. Obviously the hormone level will be disbalanced, so insulin will be low, and in those patients also they can develop a diabetes because of the less insulin, which is because of the defective pancreas, not because of the insulin resistance, not because of the destruction, it is because of the pancreas. Okay, so that is also known as the hybrid diabetes. One such example is pancreatic diabetes seen in the fibrocalculus. Fibrocalculus means once there is healing, there will be fibrosis as well as calcium deposition. That is causing the stone. The stones are known as the calculus and seen in case of chronic pancreatitis. Got it? And the presentation is catastrophic. Catastrophic means it is very deadly presentation. Why? Whenever you see in final year, whenever you come in contact with the pancreatitis patient, they are very bad. You have to manage them very acutely, and if they require more amount of fluid correction, you give more amount of fluid, they get pneumonia, ARDS, all these things. That is a very bad picture. Okay, they are very severe patients. You have to treat them very immediately, very rapidly. You have to act, otherwise you will lose the patient. You cannot save the patient. That is why this is known as the presentation is very catastrophic. Now symptoms, what can be the symptoms of in this patient? And one is the acute severe abdominal pain. You already know in case of pancreatitis there will be epigastric region pain, that is there. Steatorrhea. Steatorrhea means what? When the fat is coming out in the stool, undigested. Why it is undigested? Because the pancreatic enzyme is not there. How the fat will get digested? Right? DM with extensive pancreatic calcification. Diabetes mellitus is also there with extensive pancreatic calcification. You can see the calcification in case of CT scan or MRI, whatever you do, you can see the calcifications. And type 3 diabetes is ketosis negative diabetes. Why ketosis negative? यहाँ पे ketosis नहीं होता है. क्यों? फैट तो मेटाबॉलिज्म ही नहीं हो रहा है. फैट तो एज जैसे तुम खा रहे हो वैसे निकल रहा है स्टूल से. स्टेटोरिया हो रहा है तो फैट मेटाबॉलिज्म नहीं होगा तो कीटोन बॉडी कहाँ से प्रोड्यूस होगा? नहीं होगा, नहीं होता है. ठीक है. नाउ दिस इज
सडन होता है कि
ये सडन होता है, ये सडन होता है. कोई भी मोस्टली होता है, देखो पैंक्रेटाइटिस, मोस्ट कॉमन कॉज ऑफ पैंक्रेटाइटिस इज अल्कोहल इनटेक, ठीक है ना। तो ओवर द ईयर दीज आर मोर ऑन अराउंड 30-35 years of aged patient who is having pancreatitis. They first develop pancreatitis, not diabetes first. They first develop pancreatitis, then develop diabetes. Okay, that is why this is known as a hybrid diabetes. The reasons are not with the insulin resistance or the autoimmunity. The reasons are because of the destruction of the pancreas cells. The endocrine glands are not working properly. Insulin is not coming properly. That is why they are developing the diabetes. Got it? So this is one easy thing. Pancreas is not working properly. That is why they are getting the diabetes. In case of type 4, this is seen in case of age more than 60 years of age. Okay, it's a very benign form of diabetes, you can say. Type 4 में क्या होता है? Somebody who is completely fine in his entire life till 60 years. Okay, after that he is having diabetes. It can be age related. What we say, over the age organ starts functioning less. Okay, that happens with every one of us. Somebody precipitates at 60, somebody might precipitate at 70, somebody might precipitate at 80. So whenever this kind of diabetes are happening, these are very benign form of disease, not a severe form of disease. Slowly their sugar level will rise. If they continue with only oral tablets only, they will be fine for the lifetime. They don't require much of a medication. Okay, means not much of a complication chances are there. Okay, this will be very benign form of disease. So there is no feature of insulin resistance, no micro or macro calcification. Micro or macro calcification means there can be different types of complications that can happen because of diabetes. Macro calcification means somebody who is having diabetes all of a sudden presenting with decay, or else there is one more condition is hyperglycemic hyperosmolar state. Don't have to remember it now. These are acute complications, all of a sudden severe complication. The patient is presenting with severity. You have to immediately treat the patient, otherwise the patient will die. These are the macro complications. Micro complications, the same sugar particles, these are going and depositing in the kidneys, glomerular basement membrane is getting damaged, or in the retina, they are destroying the retina, causing diabetic nephropathy, diabetic retinopathy. These are known as the micro calcifications. Some vascular disorders that can happen because of diabetes. These are micro complications. This type has a good prognosis. Why? It's a very benign form of disease, very slow progression. Over the period of 20-25 years it might progress. Okay, so already 60 के बाद हो रहा है, ऊपर से 20-25 साल बाद जाके इसका सीवियरिटी तुमको दिखेगा, और तब तक तो उसका 85-90 साल का हो जाएगा. So that is a very benign form of disease, very gradually progressing. ज़्यादातर oral tablets से ही हो जाता है, इंसुलिन का भी ज़रूरत नहीं पड़ता है. ठीक है, can easily be managed with OHA. OHA means oral hypoglycemic agent, the tablets that we are giving them. That's all. So type 3, type 4, easy thing, nothing much to remember, nothing much to ask also from here. Just remember one thing, 3 is because of pancreas defect, 4 is because of age related. इतना ही काफ़ी है. Fine. Now, this is one of the recent updates. Some of the few recent updates, that is the MODI. Okay, maturity onset diabetes in young. Okay. What is happening in young patients, the age group is less than 25 years of age, they are developing diabetes. But these are not because of autoimmunity, not because of insulin resistance, not because of pancreas, these are genetic, completely genetic. Okay, what is happening? This transcription defect is happening in the genes. Because of that, they are developing these types of MODI. Now over here there are 7 types of MODI, and these are the genes which is responsible, which is defective in these types, because of which these types are happening. Among these 7, you can write down all these 7s, but the most important one is the type 2, type 3 and type 5. These 3 are most important and very frequently asked in the questions as well. So these 3 we have to understand. Type 2, you can see the name is little different, glucokinase. Some familiar name? It's an enzyme. It's an enzyme. Okay, glucokinase is an enzyme like hexokinase, glucokinase. This is an enzyme. So type 2 is the only MODI that is happening because of the enzymatic defect. And rest of the 1 to 7 are all because of the genetic defect. Got it? See, all these types are due to the transcription defect except type 2, which is due to the enzyme defect. The enzyme is glucokinase. And this type 2 is most commonly seen in children. Okay, that can also be asked. Type 2 MODI is seen in children and it does not require any drugs. It don't even require any drugs. This is very benign disease. On its own, it will just be there. Probably some bit of blood sugar should be 80 or to 100. It is maintaining up to 120, 125. And it is maintaining like that only. No progression of the disease. That is why don't require the medication that much. Okay. Type 3, it is the most commonly seen in India as well as worldwide. This is the most commonest. So what can be asked is, which one is most commonest? Type 3. Which one is commonly seen in children? Type 2. So that is why type 2 and type 3's enzymes are also being important. Type 2's enzyme is glucokinase and type 3's genetic defect is the HNF1 alpha defect. That's all. Okay. Type 5 is the one that can complicate. If any one of these 7 have to complicate, type 5 has the potential to complicate, but they don't complicate much, but it has the potential. Got it? It don't complicate much, but it has the potential to complicate, and that is the type 5 among all these. That is why 2, 3 and 5 is important to remember. Rest of the things, if you don't remember, fine. I don't have any issues. Okay? But 2, 3, 5, these 3 you have to remember. Got it? Now type 5 has the highest risk of complication, and microvascular complications can occur in all MODY types. Microvascular means in prolonged standing, nephropathy, retinopathy, vessel disorders that can develop. Not like DK, HHS ऐसा presentation कभी नहीं होगा MODY में. Okay? In MODY there is no risk of macrocalcifications and DK. That's all. There is no concept of insulin resistance. And it is well controlled with sulfonylurea. Sulfonylurea is a type of OH. It is one of the type of the oral hypoglycemic agent. No need to remember this name also. Okay? Just remember what you have to remember from the MODY. Type 2, type 3 and type 5. 2 common in children happening because of enzyme defect, glucokinase. 3 and 5 because of transcription defect. 3 is most common in India and worldwide. 5 has the highest chance to complicate. Even if it complicates, it can complicate into micro complications only. Macro complications are never seen in MODY. Do not require that much of treatment also. Even if it requires treatment, only oral treatment is enough. Got it? Fine. So this is a case. Now we have told you that type 1, 2, 3, 4, 1.5, everything, all the types are done. Right? Now there can be 2 types of complications in case of diabetes. One complications can be acute complication, another complication can be chronic complication. What do you mean by acute complication and chronic complication? Acute means within short period of time it is complicating, and chronic means over a long period of time it is complicating. So DKA is a example of acute complication. The patient developed diabetes, all of a sudden within a short period of time they complicated into DKA. So DKA is an example of acute. DKA, and another is the HHS. Okay, HHS full form is hyperglycemic hyperosmolar state. Okay, till now we were getting the blood sugar in type 1 and type 2 how much? Around 300, around 280, like this much, right? In case of HHS, the blood sugar level is more than 600, that high. Okay, and when the patient is presenting with DKA, the blood sugar level is 400 to 600, something between that much. Okay, so these two are that severe. You can understand by the level of the blood sugar how severe these are, and that is how they are acute. Example of chronic complication can be, one is diabetic nephropathy. What do you understand by this? Kidneys are getting damaged because of long-standing diabetes. Okay, and another one is diabetic retinopathy. What do you understand by that? Retina is getting damaged. In simple word, that is the meaning. Retina is getting damaged, kidney is getting damaged. Kidney is getting damaged means diabetic nephropathy. Retina getting damaged means diabetic retinopathy. That's all. Okay. Now let's see the case. What is happening? A 56-year-old male patient who is a known diabetes mellitus presented with diminishing vision. Okay. So vision defect is there in both the eyes over the past 1 to 3 months. He has past ocular history which includes laser treatment for diabetic retinopathy. So they have already told you that patient already had retinopathy, for which the patient had laser treatment as well. Right now the patient is again having more diminution of vision. So it's a complication of diabetic retinopathy also. Already the patient had diabetic retinopathy, it is complicated more. Patient already took laser treatment but it is not working. Now revealed proliferative diabetic retinopathy, which is worse in the left eye, and neovascularization is there, and pre-retinal hemorrhage is also there. He was diagnosed with a high risk proliferative diabetic retinopathy in both the eyes and hypertension. Now things are little complicated over there. Now let me break it down for you. First of all, they are saying what? Neovascularization. What do you understand by the neovascularization? What happens is, Let's say this is the eyeball. Okay, you did not have finished your eye anatomy also, so just try to understand the rough idea. This is eyeball, this is our cornea, this is where the light is coming and falling into the retina. This is the layer which is there in the retina. Okay, this layer is the retina. Now in this retina there are multiple small vessels are there, blood vessels are there, okay, all over the retina. Obviously it needs the nutrition from the blood vessels. Now what happens in case of diabetes? Let's say this is the blood vessel which is present in the retina. This is a zoomed version, okay. This is the blood vessel. What is happening? There are multiple small cells are there, okay, which is known as a pericyte. Okay. Now what happens? These glucose particles will get into these cells. The pericyte will get filled up with the glycosylated products. Once this gets filled up, they will form this bulge, and after that this will rupture. Once this ruptures, from here the bleedings will come out in the surrounding tissue like this. Bleedings will come out. Okay, that is causing the pre-retinal hemorrhage. Okay, you got it? Pre-retinal hemorrhage. Pre means in front of the retina there is the hemorrhage because of the destruction of the pericytes and the blood vessels. And neovascularization means whenever these are getting damaged, over there is a new blood vessel which is getting developed. Okay, neovascularization, नए तरीके से vessel develop करना. That is the meaning of this word, neovascularization. नए vessel develop करना. Okay, so these are the two things that is happening in case of diabetic retinopathy. Once there is neovascularization, another one is the destruction of the pericyte which is causing the pre-retinal hemorrhage. Okay, basically whenever a patient comes with diabetic retinopathy, what we have to do? Proper control of the sugar. You have to control the sugar, and we can do the ablation of these areas. जहाँ जहाँ से bleed हो रहा है उसको लेज़र से जला सकते हैं, लेज़र एब्लेशन करते हैं. अगर उससे भी काम नहीं कर रहा है तो फिर हमको एंटी VEGF इन द आई वी कैन गिव सम इंजेक्शन. ओके, वो इंजेक्शन किस काम के लिए दिया जाता है? टू रिड्यूस दिस न्यूवास्कुलराइजेशन. ये वेसल फॉर्मेशन को रोकने के लिए दिया जाता है. दैट्स ऑल. यहाँ पे वो पेशेंट का सेम ही किया गया है. पहले लेज़र किया था, वो नहीं हुआ, फिर उसके बाद हमारे पास ऑप्शन है कि उसका बीपी कंट्रोल करो, शुगर कंट्रोल करो और गिव देम दैट इंजेक्शन थ्रू द आई, so that neovascularization stops. If that also not helping out, then we can burn the whole retina with laser. With laser we have to burn the whole retina, and only the center portion of the retina, that is the macula, that is active. Baki patient becomes completely blind with it. Completely narrowed down. There will be only tubular vision. Only the macula can sense the light. Other than that, nothing can sense light. So right now you can see the whole thing, the periphery is there, everything you can see. In that patient, let's say you are seeing through this pen, right? You are seeing through this pen. Up to how much vision you will get? Only this much straight. I cannot see whatever is happening around. So this is known as a tunnel vision, just like a tunnel. So if you are doing, patient is getting that complicated, we have to burn the whole retina with a laser ablation, and then the patient only remains with the tunnel vision.
And if you don't treat it, you can go to that tunnel vision.
Tunnel vision होता नहीं है. Patient cannot see. Ultimately will come to you and you have to burn the whole retina. Got it? Ultimately the patient will have tunnel vision only. If you burn the whole retina, let's say this much whole retina is responsible for your vision, and only this much portion is remaining, and rest everything you have burned. Right, so this much portion only can perceive the light, and through this much only जितना तुम्हारा vision zone है उतना ही तुमको दिखेगा.
No, but if it is untreated, then what will be the vision?
It will keep on increasing. If it is untreated, obviously the patient is having decrease in diminution of vision. If you do not treat it, or if you do not control the blood sugar, yeah, completely it will be gone. You cannot save it. You cannot save it. So that is a case of diabetic retinopathy, chronic complication of the DM. Easy to diagnose. If the patient is having, if the question is given you with diabetes history, long-standing diabetes history or hypertension, and right now the patient is complaining of diminution of vision, most likely diabetic retinopathy. Nothing difficult to identify. Okay, but why is it happening? First of all, one is the duration of DM. The more the duration, the more will be the complication. Uncontrolled DM, somebody who is regularly taking medication, somebody who is not taking medication. If somebody who is not taking medication, that is uncontrolled DM, more chances of developing retinopathy. And type 1 DM is more severe than type 2. Okay, in case of type 1, even though it's a rapid onset, but if they develop retinopathy, that will be much more severe as compared to the type 2. Got it? Okay. Now, symptoms of the disease. One can be gradual painless vision loss. One can be sudden painless vision loss. Gradual means slowly the vision is decreasing. Today you can see this much. Next day you can see a little bit more closer, and after that you cannot see only. That is a gradual. Okay, over a period of time that is happening. And sudden pain loss means all of a sudden you cannot see anything. All of a sudden your vision is lost. Okay, so why this happens? Gradual painless vision loss can happen because of cystoid macular edema. What happens is, in the retina there are 10 layers. Okay, when you will go to your anatomy and ophtha, that time you will know there are 10 layers of retina. What is happening between the 10th and the 9th layer? There are some fluid collection. Okay, so the retinal, let's say these are the 9 layers. Okay, and this is the 10th layer. The layer should be like this, attached with each other. Now what is happening in between? There is a fluid collection and layer becomes like this. And this is known as the cystoid macular edema. Okay, because of that, edema means fluid collection. So between these two layers there is a fluid collection. Because of that, the light perception is reduced. Okay, and that is why this is a gradual, slowly, because the fluid all of a sudden won't come. Slowly the fluid will increase. The more the fluid, the more will be the decreased vision. Got it? In case of sudden painless vision loss due to pre-retinal hemorrhage, like these pericytes, all of a sudden this will rupture. This will not rupture slowly. Rupture means rupture. Fat gaya, matlab fat gaya. So all of a sudden the vision loss will be developing. Got? Okay. Now pathogenesis. How is it happening? Diabetic retinopathy is a vascular complication. I have already told, just see the words. Diabetic retinopathy is a vascular complication of diabetes where the surrounding retina, there are vessels and pericytes are present. So around the retina there are blood vessels and pericytes are present, which are now the DM, the glycosylated products are accumulating into the pericytes. Because of the diabetes, the sugar-rich products are getting accumulated into the pericyte. Later on, the pericytes are getting destroyed, and in those places microaneurysm occurs. Okay, easy to understand? Okay. Now, there can be two types of diabetic retinopathy. One is a non-proliferative, another one is a proliferative. Okay, no need to understand, no need to go into that depth. What is proliferative, what is non-proliferative? When you will go in your ophtha, 3rd year, that time you have to know in detail about it. What is proliferative, what is non-proliferative, how proliferative can be divided into multiple stages, how non-proliferative is divided. But yeah, in any of the cases, cystoid macular edema can occur in any stage. What is cystoid macular edema? This one, this fluid, 9th and the 10th layer, if there is fluid accumulation, this retina gets detached. Because of the detachment, you will have diminution of vision. Okay, fine. Now another case. We have already discussed diabetic retinopathy, right? Now another case. A 45-year-old male patient comes to the OPD with complaints of anorexia. Anorexia means decreased appetite, when your appetite is low. Nausea, vomiting. These are some common symptoms that can be there in many diseases. So these are not diagnostic. Decreased appetite can be there in fever also. Nausea, vomiting can be there in case of fever also, viral fever also. So these are not disease specific symptoms. These are there. Okay. Now foamy appearance of the urine. Anything recalls in your mind foamy appearance of urine where you can get protein. If the protein is present in the urine, this gives foamy appearance of the urine. Now decreased urine output since last few days. Okay. Urine output is less. Means kidneys are functioning not properly. Most likely. Something or the other clinical hint you are getting, the urine output is less. If the kidney was functioning properly, then the urine output should be normal as well. He also complained of swelling of the legs. If the fluid that was supposed to come out as urine and that is not coming out because of the defect in the kidney, obviously the fluid is there in our body, it gets deposited mostly in the legs, face or in the abdominal gutters. Okay. In case of kidney patient, the most common place is legs. Why? Most of the time we are standing or working. The most dependable part is the leg. That is why it goes there. As well as in the face. Whenever you are sleeping, the fluids are coming into the face, and early in the morning you can get more of the puffy face. Okay, swelled up face. So swelling of the legs, puffiness of the face, which is more in the morning. And the patient is a known case of hypertension and diabetes and under irregular medication. Okay, the patient is having diabetes and hypertension since last 10 years, but the patient is not taking medication properly, and that is why it complicated. Got it? Okay. Now you have done the lab investigation. What are you getting in the lab investigation? Fasting blood sugar high, PPBS high, HbA1c high. Why HbA1c is high? Irregular medication. Okay. Lipid profile dearranged. Dyslipidemia is there. Dyslipidemia is there means most likely type 2. Okay. Serum urea 130. Normal is less than 45 to 50. Less than that much is normal. Serum creatinine 2.5. Normal is less than 1.2. Okay. So serum creatinine is also high. Urea is also high. And these two are the marker for the kidney function. I tell you again, urea and creatinine are the marker of the kidney function. If your kidney is functioning properly, then the urea and creatinine should be normal, within the normal limits. Now these two are increased means the kidney is not functioning properly, whatever the reason is. And more likely in this case, the diabetes is a long standing, could be because of that the patient is having diabetic nephropathy. In case of urine analysis you have done, urine analysis you are getting glucose is present. Protein is also present, so you can confirm one thing, like it is diabetic nephropathy only. That is why the kidney is not functioning properly, losing the glucose as well as the protein in the urine. So that's why both are present. And another one is urine ACR. Now urine ACR is what? Albumin creatinine ratio, which is high. What is urine ACR is? We measure it for to see microalbumin. Now we all know the albumin and globulin are the major proteins in our body, right? So whenever a patient is developing the diabetic nephropathy in the very early stage, the patient don't start losing albumin and globulin in the very first day. What will they lose? Microalbumin, small particles of the protein. That kidney cannot filter it out and it is getting out. Okay, and rest of the big chunks of the proteins kidney is filtering out because it is just the initiation of the disease. Okay, so if we estimate the this KFT, urea creatinine, it might be little bit normal only, might be 60, creatinine might be 1.2 only. So it is a very early stage, and that time if you check the urine analysis also, your protein will be absent and glucose is present. Okay, but if you check for the urine ACR, that is checking the microalbumin, that will come positive if it is in the early stage. So in the very early stage, if you want to diagnose the case, you have to check for the urinary ACR level. Got it? Any doubts?
So what is HTN?
HTN means hypertension. Short form. HTN means hypertension, DM means diabetes mellitus. That's all. Sorry for the short forms. KCO means known case of. Okay. So these are the short forms. You will get acquainted more and more often you hear it. Okay. Fine. Any doubts? Any other doubts from this? Easy to diagnose. You have to see first sugar is present, kidney functions are deranged, urine analysis, glucose, protein both are coming, diabetic nephropathy. No questions asked. Urine ACR is high means it is already covered the early stage. Initial जो stage था वो already cover कर लिया. That's why the proteins are also present in the urine analysis. If it would have been absent, protein would have been absent, and ACR is high, that means it's a very early stage of the diabetic nephropathy. Diabetic nephropathy is there, but it is the very early stage. And this case, the urea and creatinine should have been little bit much lesser. Okay, got it? Now, what are the causes? There are three major histologic changes which occur in the glomeruli in case of diabetic nephropathy. You all know from the physiology what is the structure of glomerulus? Structure of glomerulus? Okay. Let me tell you one thing. Why this diabetic nephropathy is developing? Let's say this is your glomerular basement membrane. Okay. This is your glomerular basement membrane. From here the blood is coming and over here the blood is going out. Okay. And this is the mesangial cells which is there, okay, which is filtering out the blood. This is the efferent, this is the afferent, let's say. Fine. Now blood is coming, filtering out over here and then going. Now what is happening in case of diabetic nephropathy? There are some basal cell and the mesangial cells. These mesangial cells are proliferating, means number is increasing. Okay. If the number is increasing, this part will be more thicker. This basement membrane will become more thicker. So first of all the cells are increasing in number, the mesangial cells are increasing in number, then the basement membrane which should be thin. Let's say if I am taking one paper and I am putting water and I am taking 10 papers together and then I am putting water, through which the water will be less filtered. 10 papers, because the thickness is more. The more the thickness, the less will be the filtration. Over here, because of the increased proliferation of the mesangial cells, the basement membrane becomes more thicker, and that's why the filtration also reduces. Okay, one thing. Second thing, once this portion gets this thick, later on this also heals up. Once it heals up, again the healing process with the fibrosis only, and they get attached to each other. That is known as the glomerular sclerosis. When they fix with each other, once they become fixed, filtration is again lost. Got it? So these are the histology, means if you see under the microscope what kind of changes you can see. First, there are three changes. One is the mesangial proliferation. Second change, there will be thickness of the basement membrane. Third change, there will be glomerular sclerosis. In the process of healing, they become adherent to each other. They adhere with each other, and that becomes sclerosed. Sclerosed means which stickily attaches with each other and becomes very stiff. Now you cannot take it out. That is the meaning of the sclerosis. Fibrosis. These are the similar kind of terminologies. Okay. Now, once a patient develops this renal diabetic nephropathy, they will ultimately lead into kidney failure. Okay, over the time, if you don't maintain your blood sugar level, or if you don't maintain your kidney function, then it can lead into kidney failure only, and that takes more or less up to 10 years. Okay, if you don't maintain, if you maintain, then it can be even more than that also. And in certain condition, that urine ACR I told, if the urine ACR is more than 30, then there is a chance of developing this renal failure much earlier than 10 years. Means already more and more amount of microalbumin is losing. That is why the development of kidney failure can be much more earlier. Okay. Now, how to detect? The urine ACR level should be checked as soon as the diabetes is diagnosed and measured annually or half yearly for the early detection of the diabetic nephropathy. Now, let's say somebody who is coming to you with a diabetes. Okay, you have confirmed that case that it is a type 1, type 2, whatever the diagnosis is. You tell the patient to go through a urine ACR. Once the patient comes with the urine ACR report, you see if it is normal, then every yearly or 6 monthly, you tell them to do this test again and again, to keep a track कि बढ़ रहा है या कम हो रहा है. If it is increasing, then it is going towards nephropathy. That is for the early detection of the nephropathy. That is why urine ACR is important. For you people, what you have to know is which test is important, that is a urine ACR, and why it is important to identify the early cases of diabetic nephropathy. Okay, that's all. And classification, there is a society for the kidney diseases. Okay, that is known as the Kidney Disease Improving Global Outcome, in short known as the KDIGO. Okay, this society have classified the stages into 5 stages. You all know about the GFR, glomerular filtration rate, like how good the kidney is functioning. To measure that, we measure the glomerular filtration rate. In the stage 1, the glomerular filtration is more than 90. The normal glomerular filtration rate is 125. Okay, if it is more than 90 and only microalbumin is present in the urine. Okay, so what you will get, the glomerular filtration rate is more than 90 and urine ACR will be high. Okay, to measure the microalbumin. So that could be stage 1. And over the period of time, if you don't maintain, the GFR keeps on decreasing. Okay, and depending upon the GFR, you can stage them at stage 1, 2, 3, 4 and 5. And stage 5 means end stage renal disease. Over here in this stage, we have nothing much to do. Most likely you have to go for dialysis or transplant. We don't have any other option to treat. Before that, jitna control karna hai kar lo. Once this comes to stage 5, you have to go for dialysis or transplant, kidney transplant. After that, कुछ करने का नहीं होता है. Diabetic nephropathy can lead to ESRD if not managed properly. Obviously, if you don't manage it, it will lead into end-stage renal disease. And if urine ACR is above 30 mg in the initial stage, that indicates higher risk of kidney failure. Right? Any doubts? Okay. Merry Christmas in advance and Happy New Year in advance.